Introduce our speaker. Eric, welcome.
Thank you, Dr. Desir. It's really a pleasure for me to present Dr. Rui Hu, who is going to be giving our presentation today. Just briefly, to introduce Rui to the audience who don't know him. Rui completed his undergraduate degree at Princeton before pursuing a master's in public health at Johns Hopkins, and then going on to Vanderbilt for medical school, where he stayed for internal medicine residency. We were extremely fortunate to match him here to cardiovascular diseases training and fellowship, where he is in his third year and exceptional in many regards. It's quite fitting today that we recognize Peggy Bia and her teaching through these awards, because Dr. Hu has won, I think, pretty much every award for teaching here in the 3 years. I hope I remember this correctly. I actually had to write this down. In 2021, he was recognized by this group and the medical students for excellence in teaching. In 2022, he was given the Fellow of the Year award by the internal medicine residents. And in 2023, he was recognized by the emergency department as the consultant of the year. And so he's an exceptional and dedicated educator, and it's exciting to see him build those skills and continue to impact the lives of those that he's working with. Now, while he's excelled in education, he really has been impressive in so many ways in his inquisitiveness, innovation, and productivity as an investigator while being a very busy clinical fellow. He, I think, is focused on innovations in digital tools, and that's not surprising to me, as he's fluent in 9 programming languages. And so with that introduction and a recognition that he's received multiple awards from the American Society of Nuclear Cardiology, the American College of Cardiology, and other recognitions of the work he's done to date, I'm excited to introduce Rui to give us grand rounds this morning. Thank you, Rui.
Yeah, sure. You. Okay. All right. Thank you, Dr. Desir, Dr. Quagliarello, Dr. Siegel, for the opportunity to speak today. And thank you, Dr. Velasquez, for the kind introduction. I am so excited to tell you all about building digital tools to model decision-making in cardiology. I have no disclosures. Most of the House staff at this point are familiar with and have made use of my teaching materials in the CCU and the Goodyear service, and I'm grateful for your continued use. But can we transform these paper summaries into interactive tools for MedEd? That is what today's grand rounds will focus on. Here are some learning objectives, and we will start by discussing stress testing. It is not uncommon to need to order a stress test from primary care clinic, but which stress test is the right stress test to order? There are so many options in Epic. Across the country, there's high variability in the overuse, underuse, and misuse of different cardiac testing modalities for ischemic heart disease. We know that appropriate choice of cardiac testing may reduce unnecessary radiation exposure, procedural patient risk, and adverse economic impact to patients and society. Many specialty societies have put together appropriate use criteria, or AUCs. But although these are carefully constructed, AUCs have had limited uptake in practice due to discrepancies in scenarios and definitions across different society documents, the sheer number of scenarios, the multimodality nature of stress imaging, and the flat nature of PDFs, which are hundreds of pages long. For example, in this 2014 multimodality AUC for stress imaging, it does not distinguish between SPECT and PET. It does not distinguish between exercise SPECT and regadenoson SPECT. Within stress echo, it does not distinguish between exercise stress echo and dobutamine stress echo. How do you know which of the 20 order options to pick in Epic when even our AUC documents in cardiology do not explicitly specify the distinction? Another problem is that some societies will enumerate extremely detailed scenarios, which you see here for PET stress tests, but these scenarios are not covered by other societies. We wanted to create an interactive, scenario-based tool for clinicians to receive instantaneous feedback on whether the stress test they are planning to order for their patient is always appropriate, maybe appropriate, or rarely appropriate for 10 modalities, including treadmill, SPECT, PET, stress echo, MRI, coronary artery calcification, coronary CTA, and cath. This required harmonizing all AUC documents for stress imaging and developing a rule-based imputation for non-specified scenarios, i.e. the scenarios specified by some societies' guidelines, but not by others' guidelines. This was an arduous undertaking by Drs. Trejo Paredes, Wright Essen, and future Dr. Maya, with the help of Drs. Feher and Miller. Throughout this presentation, I'm including photos of the individuals involved because these individuals have devoted uncountable hours in either coding, flowcharting, data collection, design, or editing, and I want to recognize the contributions. You are probably familiar with the Choosing Wisely campaign of the last decade, led by the American Board of Internal Medicine. I thought, we need a Stressing Wisely campaign. So I bought stressingwisely.org. To accomplish this goal, we constructed a menu of options that reconciles the definitions used across different society documents, including symptomatic and asymptomatic reasons for investigating, prior revascularization, typicality of symptoms, cardiovascular risk factors, age group, result of initial cardiac testing, and preoperative characteristics if applicable. For each scenario, we inputted the rating of the most recent applicable guideline, the rule used to arrive at that rating, and the evidence document and table associated with this. We repeated this process for 2,186 different scenarios. In the next step, we created comprehensive matrices consisting of feature scenario keys, scenario rating keys, and rating justification rule keys. In addition, each rating and rule is associated with an evidence document and specific table from that evidence document. All ratings were performed by a pair of cardiology fellows here and reviewed by a pair of cardiac imaging attendings in a blinded manner. This table shows the resulting distribution of appropriate, maybe appropriate, and rarely appropriate ratings. This includes 10 modalities, as I mentioned, and also the option for no test. We made 24,000 ratings with 96,000 possible permutations. Using R, Shiny, JavaScript, PHP, and MySQL, I coded a graphical user interface for clinicians to interact with the unified guidelines. Clicking on the book icon reveals the definitions to the user. Let's say we have a patient who has anginal symptoms, no known CAD, atypical angina, 2 or more cardiovascular risk factors, age 72, who just had an exercise treadmill test that was equivocal. The user can also pick from a menu of contraindications, which we weave together from 5 different society documents. So let's say our patient ingested some caffeine last night. The app will then generate recommendations, and let me pause this over here. So it'll say, here's the scenario. Here we have a more than 50-year-old symptomatic patient with no known CAD, atypical angina, 2 or more cardiovascular risk factors, and prior abnormal exercise treadmill test, no Duke score specified. So it's going to give you a recommendation or rating for each of these modalities. For example, exercise treadmill test is not applicable because you just did it. There's no point doing it again. Exercise SPECT is appropriate for an indication. Pharmacologic SPECT is also appropriate for the indication, but it's contraindicated by the fact that he ingested caffeine in the last 24 hours, and so on for Pharm PET, exercise echo, and pharmacologic echo. In addition, if you're curious about where our rating came from, you can visit the associated guideline document and the specific table reference as follows. This one was from the 2023 multimodality AUCs. In the second example of a preoperative patient, because the patient is going for a low-risk surgery and has a low pretest probability, all testing modalities are considered rarely appropriate. These are examples of how this tool can provide a comprehensive assessment of multimodality imaging for coronary artery disease. How does this compare to what we currently have in EPIC? Currently approved clinical decision support mechanisms, or CDSMs, are optimized for billing and for hospital profits, not for patient care. You've seen this screen whenever you try to order a radiologic test of any sort, including non-cardiac radiologic tests. Current CDSM systems require a user to retroactively select a, quote, approved indication for an imaging test order so that the imaging test can be billed to the patient and covered by insurance. These CDSM systems make no effort to change the mind of the ordering physician about the appropriateness of the test being ordered, nor do they suggest alternative tests that are more appropriate. In contrast, in our reverse approach, Stressing Wisely provides appropriateness ratings for a range of imaging and non-imaging cardiac tests, including the option of no test, so that the ordering physician can make an informed, guideline-supported decision about the right test to pursue for the patient. Therefore, Stressing Wisely represents a successful prototype in which a computational approach can weave hundreds of pages across different society guideline documents with discrepant definitions into a point-of-care educational tool that addresses a quality gap. That wraps up our overview of Stressing Wisely. Now, another central issue in internal medicine is the handling of guideline-directed medical therapy, or GDMT. While it is widely known by everyone at this point that GDMT improves survival and reduces hospitalizations, there remains uncertainty about which GDMT medications can be started at which stage of kidney disease in which patients. Therefore, we created GDMT for Everyone, which anyone can visit at gdmt.org. Patients with heart failure with reduced ejection fraction and CKD or ESKD are a vulnerable population with triple threats. First, CKD and ESKD have independent mortality risk factors in heart failure. Second, over half of randomized controlled trials in cardiology exclude patients with advanced CKD or ESKD. These patients are less likely to receive GDMT medications approved for their stage of kidney disease. Full GDMT is prescribed in only 25% of eligible CKD3A patients, down to 3% of ESKD patients. The presence of CKD was the most commonly cited reason for not up-titrating GDMT in biostat-CHF. So, if you visit gdmt.org, you will be able to see a summary of every GDMT agent and GDMT adjacent agent and a quick summary when you hover of what is allowed at each stage of CKD or ESKD. Clicking on the specific cell will bring up direct quotations from the ACC, AHA, HFSA, and KDIGO guidelines about what can and cannot be done. Now, clicking on the medication name itself can bring up guidance on the dosing of medications. So you'll notice that in addition to things like SGLT2, I also included things like statins, which you'll see shortly. So just guidance on dosing of statins, medium, moderate, high intensity. And as I mentioned, this tool is grounded in the recommendations from the 2022 guidelines from the AHA, ACC, HFSA, and KDIGO. Now, if you were a primary team, you could take this a step further and say, well, my patient is on lisinopril, metoprolol, and spironolactone. So what do I need to do? So it's going to say, consider switching to this medication, an ARNI, i.e. Entresto. That's a class 1 recommendation, switching away from ACE inhibitor, the lisinopril. You can continue this metoprolol succinate, but consider up-titrating it from 12.5 to 25, and you can consider going until you reach target dose, and consider starting the spironolactone, MRA. So here in the next second, we started MRA, and now let's change this lisinopril over from Entresto. So you can see it's happy now. Let's restart from over here. And so I want to illustrate this point over here. So, you know, we started Entresto, and it's going to tell you, okay, now that you started Entresto, keep on going up to 49.51, to 97.103, until you reach target doses that are maximally tolerated by the patient. It says SGLT2 is a class 1, so we start that. Now you can also plug in the ferritin and transferrin saturation. So when that meets criteria, you can consider repleting the iron. That's a 2A recommendation. If we give the patient an AKI, it's going to tell you to hold the ARNI, MRA, and SGLT2. Let's take away the AKI. In addition, in the newest version of this tool, it can also handle HFpEF and HFrEF in addition to HFrEF. So you'll see when we change the ejection fraction to 55%, beta blockers no longer have a recommendation based on AHA, ACC, although that's different in ESC. And when you change it to HFrEF, they come back with a 2B recommendation. So this is available for everyone to use. In developing any software, we need to test not just happy paths, which is when users click through with expected input and the program executes without exception, but also unhappy paths. Unhappy paths refers to any scenario in which the user's input leads to an ungraceful handling of an exception and leads to a premature end state or an incorrect end state. There's usually no limit to the number of unhappy paths. Testing for edge cases and corner cases includes things like ensuring systolic blood pressure is higher than diastolic blood pressure, which is something you would never encounter clinically, but this must be specified to the computer. Or ensuring that ACE inhibitors, ARBs, and ARNI are not simultaneously selected. So these are checks that you have to build in. I want to give a shout out to Chief Resident Lexi for helping to write this piece about what to order to layer on quadruple therapy for HFrEF. There are some very important points in here. Please check it out. Who uses GDMT for everyone? According to Google Analytics, GDMT.org regularly receives users from around the world, including 76 countries. And it's most popular among internists and cardiologists. This is an internal survey. It's widely used by residents, fellows, and attendings. As you're watching each demo in today's presentation, I invite you to think, how can this pertain to you and your patient care? Can I use this in my teaching on rounds? Can I adapt this to my own specialty? Can I translate this into my native language or bring these tools to resource poor settings? Now, moving on from GDMT. One of the most common issues in bread and butter internal medicine is that of the asymptomatic troponin elevation. In a small survey of cardiologists and cardiology fellows, 90% agree with the statement, I have seen situations in which serum troponin is ordered in the absence of anginal symptoms very frequently or frequently. And 87% agree with the statement, I have seen situations in which serum troponin is ordered when there's no cardiac presenting issue, such as here for a hip fracture, very frequently or frequently. A study in JAMA Internal Medicine found that serum troponin testing is performed in 47% of inpatients, including 35% of inpatients without anginal symptoms. In 2022, medicine hospitalists at Brown University examined discharge summaries and problem lists of patients who had 2 or more troponin measurements and a rise and fall pattern. They found 19 different troponin terms used in discharge summaries. Many of these terms are imprecise, incorrect, or have been phased out since the 4th universal definition of myocardial infarction that was published in 2018, such as NSTEMI type 2. Something can be NSTEMI or STEMI, or it can be type 1 or type 2 MI, but there is no longer an entity called NSTEMI type 2, according to the 2018 definitions. The study authors noted that more precise language may facilitate appropriate evaluation and management of these higher risk patients. Therefore, we decided to create the Troponin Toolbox, which we are launching at www.troponin.org. On this tool, you can input the first and second troponin values, select the assay use at Yale's Roche and elapsed time at Yale's 60 minutes, and the app will tell you that this particular pair of troponin values has a sensitivity of 83.8 and specificity of 91.9% for ACS. You can take it a step further and input features gathered from your history of present illness. If the chest pain is worse with exertion, that carries a positive predictive value of 18 to 21 for ACS and a positive likelihood ratio of 1.5 to 1.8 for ACS. So there's that. How about comorbidities and ECG features? You can do that too. T-wave inversion carries a positive likelihood ratio of 1.8 and PPV of 21 for ACS. You can expand this for any number of features and it'll provide you with the LRs and the PVs. Now, let's say you have an echo that comes back normal, a CTA that comes back normal, and you're trying to reassure yourself that this patient is fine. The absence of features also carries its own negative likelihood ratios and negative predictive values. As a user, you can customize whether you want to get likelihood ratios, predictive values, sensitivity, specificity, or all of the measures. Where did we get the evidence? These numbers came from COMPASS MI, a study of high-sensitivity troponin trends in 15 international cohorts, and from the JAMA Rational Clinical Examination, meta-analysis of what aspect of the HPI signifies with respect to ACS. So we did not make any of these numbers up. These are validated diagnostic measures. All we are doing is designing interactive tools to bring them to the point of care. That is our focus. Because we received so many questions about high sensitivity troponin, we undertook an extensive writing and illustration effort. At troponin.org, you will find useful information about all the generations of assays, analytical and clinical sensitivity and specificity, updated terminology about myocardial injury, ischemia, and infarction, journal club summaries of key troponin papers, and clinical vignettes of how to interpret troponin in different settings. I will go through a few key highlights that I think are important nuances for everyone to know about. You've heard these terms thrown around a lot. What exactly is the difference between myocardial injury, myocardial ischemia, and myocardial infarction? The term myocardial injury applies to any patient with a troponin value above the 99th percentile of the upper reference limit, regardless of the underlying cause. If there's no troponin elevation, there is no myocardial injury. The diagnosis of myocardial ischemia requires at least one of the following: ischemic symptoms such as exertional chest pain, pressure, or dyspnea, or ischemic signs such as new ischemic ST or T wave changes on ECG, new pathologic Q waves, or wall motion abnormalities on an ischemic pattern on echocardiography. Myocardial infarction is defined by the presence of both acute myocardial injury and evidence of myocardial ischemia. Pathologically, MI is characterized by cardiomyocyte necrosis, with necrosis progressing from the subendocardium to subepicardium over the course of several hours. Now, when you've reached this box in the black, the diagnosis of myocardial infarct, that is the point where you can self-specify the type of MI. There are actually 5, not 2 types of myocardial infarction. What are they? A type 1 MI is caused by atherosclerotic plaque rupture or ulceration and results in intraluminal thrombosis, which can be occlusive or non-occlusive. The appearance of new ST segment elevations and at least 2 contiguous leads indicates a STEMI, whereas a lack of ST elevation indicates that type 1 MI is an NSTEMI. Type 2 MI is characterized by a mismatch between myocardial oxygen supply and demand without an acute plaque rupture event. The demand-supply mismatch in type 2 MI can occur in the setting of no plaque or in the presence of some plaque, as illustrated by the last and first examples on the right. Type 2 MI may also occur from microvascular dysfunction or coronary vasospasm, as indicated in the second example, or by spontaneous coronary artery dissection, or SCAD, as indicated in the third example. The diagnosis of type 3 MI is reserved for patients who present with typical signs and symptoms of MI, but dies before cardiac biomarkers are measured, such as an individual who complains of chest pain while driving, crashes his car from VFib arrest. Procedure-related MIs, typically within 48 hours of the procedure, can be type 4 or type 5. PCI-related MIs type 4A. MI caused by early or late stent thrombosis is 4B. MI caused by in-stent restenosis is type 4C. And CABG-related MIs type 5. I want to give a shout out to Ilhan, who's sitting here, MD PhD student, for these beautiful illustrations. So if we were to think back to the preceding slide, all conditions exist on a spectrum. A patient who comes in with a GI bleed resulting in a hemoglobin drop, but who has normal troponin, no chest pain, and no ECG or echo changes, has anemia with no myocardial injury. Whereas a patient who comes in with a GI bleed resulting in a hemoglobin drop plus an elevated troponin, but who denies chest pain, ECG, or echo changes, and that person has anemia with myocardial injury, but without myocardial ischemia. And then a patient who comes in with a GI bleed resulting in a hemoglobin drop plus an elevated troponin plus either chest pain or ischemic ECG or echo changes has anemia with myocardial injury plus myocardial ischemia resulting in myocardial infarction. So that is the key distinction. So how do we put all of this together? Feel free to snap a photo of this slide because it will help with clinical documentation. First, is the troponin abnormal above the 99th percentile upper reference limit? If it is not, then you can say there's no myocardial injury. If there is myocardial injury, and you need to look next at whether the troponin has a rise and fall pattern above 20% to determine if it's an acute myocardial injury or a chronic myocardial injury, as you see in ESKD. If the myocardial injury is acute, you then want to see if there's anginal symptoms or ECG or echo changes that would suggest the presence of acute ischemia. If there are no anginal symptoms or ECG or echo changes, you should document that this is a non-MI troponin elevation secondary to specify the underlying condition. If there is acute ischemia, then you are witnessing the clinical correlate of cardiomyocyte necrosis resulting in acute myocardial infarction, which was the black box several slides ago. If you suspect atherosclerotic plaque rupture, or you have confirmation of this on angiography, then it is a type 1 MI. If you suspect demand-supply mismatch, then you want to document it as a type 2 MI secondary to specify the underlying condition. In type 2 MI, you do not distinguish between STEMI and NSTEMI. That terminology is only reserved for type 1 MI. So that's one of the most popular misconceptions even today. Between the 1980s and 2020s, we have seen the evolution of troponin assays from first to fourth generation to high sensitivity. In the coming years, we might see the spread of wristwatch troponin. Mid-infrared attenuated total reflection spectroscopy has enabled non-invasive measurements of troponin through the skin. The results of the first prospective trial of this non-invasive transdermal troponin quantification by wristwatch was unveiled at ACC in 2023. Therefore, the art and science of interpreting serum troponin is increasingly important for all clinicians as successive generations of troponin assays have increased the sensitivity, precision, and speed of testing, coming at the expense of decreasing specificity. How do you convert between fourth generation troponin T and high sensitivity troponin T? With the Roche Alexis assay that we use at Yale, values above 100 on the high sensitivity assay correspond linearly and 1-to-1 to values above 0.1 on the fourth generation assay. So a value of 300 nanograms per liter corresponds to 0.3 nanograms per milliliter in fourth generation. Below 100 on the high sensitivity assay, you have a nonlinear relationship. So 52 corresponds to 0.03 and 30 corresponds to 0.01. Of note, high sensitivity troponin can report results that were previously below the reference range and the lower limit of detection, including detecting troponin in healthy asymptomatic individuals. Compared to conventional troponin assays, high sensitivity assays have higher negative predictive value for acute MI, reduce the troponin blind interval, and result in a 20% relative increase in the detection of type 1 MI, which consequently decreases the diagnosis of unstable angina, and also increases the detection of type 2 MI by twofold. Given the increased prevalence of the diagnosis of type 2 MI, we undertook a massive literature review to gather the first ever compilation of the prevalence of troponin elevation in every non-ACS etiology. For example, for individuals who run long distance, in a systematic review of 16 studies, 0.6% of participants had detectable levels of non-high sensitivity troponin before the marathon, and this proportion rose to 62% after the marathon. In 2 studies that made use of high sensitivity assays in marathon runners, every single marathon runner had a detectable troponin level after the race. Knowing these prevalences from sepsis to ARDS, all of which we'll make available, will allow everyone to better contextualize the significance of troponin elevation in each condition. By February 2024, i.e. next month, I will have these available as dot phrases in EPIC that you can steal for each etiology. So, we've created all these durable educational materials, but do they work? To find out, we rolled out the troponin tool and educational portal at morning reports across York Street campus, SRC, Bridgeport, and Waterbury. And many of the people in this room have participated in this. We asked residents and medical students their level of confidence in providing definitions to distinguish between the following terms before and after the use of troponin tool and educational portal on the left and right respectively. Red indicates completely confident, purple indicates fairly confident, blue indicates somewhat confident, green indicates slightly confident, and yellow indicates not confident at all. You can see whether it was myocardial injury, ischemia, infarction, or type 2 MI versus type 2 NSTEMI, or high sensitivity troponin versus fourth generation troponin. There was significant improvement in learner confidence in distinguishing between these terms. Similarly, we asked residents and medical students their level of comfort in interpreting troponin elevations in a setting of impaired kidney function, physical trauma, immunotherapy, and a dozen of other conditions before and after the educational intervention, including the case vignettes that you saw a few slides ago of how to interpret troponin in each condition. Red indicates very comfortable, purple indicates comfortable, blue is neutral, green is uncomfortable, and yellow is very uncomfortable. Once again, there was an impressive improvement before and after the use of the educational intervention. Therefore, this approach may be useful to medical educators, not just in cardiology, but other specialties hoping to create digital tools to integrate diagnostic test performance measures into point-of-care clinical education. We are past midway through our time together and have covered the design of Stressing Wisely, GDMT for Everyone, and Troponin Toolbox. Now, I would like to give you a preview of several tools that are in the pipeline. One common inpatient issue is what to do with a patient with a pericardial effusion and whether that patient is in tamponade or not. Therefore, we designed the Tamponade Toolbox, which will come soon at tamponade.org. When you go to tamponade.org, you'll be able to see descriptions of RA and RV diastolic collapse, LA collapse, respiratory variation in right and left heart filling, and plethoric IVC. All echo images and videos can be viewed with or without annotation, and this was in response to resident requests on doing POCUS. All images are from real echoes at YNHH, and here you see an example of hepatic vein flow reversal. You will also be able to see information about physical exam findings of tamponade and what happens when pericardiocentesis goes wrong to raise awareness that the procedure itself carries its own risk and is not for everyone. In the next few months, we're undertaking a large effort to chart review all pericardial effusions and pericardiocentesis at YNHH in the last 5 years in order to generate predictive values, likelihood ratios, and prevalences for each sign, much like you saw in the troponin tool, so we can design an evidence-based tool for tamponade. Moving on from tamponade. This is a very exciting time for cardiovascular prevention, with the wealth of therapies coming through phase 3 and 4 trials. With the speed at which these therapies are becoming available, it can be confusing to figure out when someone qualifies for addition of any therapies beyond a standard statin and ezetimibe. Today, we have bempedoic acid, alirocimab, evolocumab, inclisiran, and icosapent ethyl, among many others. Too much to keep track of. Do you agree? Therefore, we present Atheroprev, a tool that helps clinicians decide which non-statin therapy they should use next. I was very happy to get ASCVD.org. The ASCVD tool, which is still in its early stages of development, allows the clinician to input patient characteristics and receive information about whether they're eligible for inclisiran, bempedoic acid, PCSK9 inhibitors, or icosapent ethyl. It also helps the clinician figure out whether LP(a) level testing is indicated. Where did we get the evidence? This tool is grounded in the recommendations from the 2022 ACC Expert Consensus Pathway on the role of non-statin therapies for LDL cholesterol lowering. In addition, it will also calculate 10-year ASCVD risk based on the new PREVENT equations just released at AHA 2 months ago. Moving on from ASCVD. Another very common issue in medicine is the management of atrial fibrillation, especially AFib with RVR. Therefore, we designed the AFib Assist tool. How can we help you get from atrial fibrillation to atrial harmony? The atrial fibrillation tool will have modules to assist with estimating bleeding risk and the decision to anticoagulate, selection of rate control agent, selection of rhythm control agent, control of rapid ventricular response, and Watchman referral. In this wireframe of rapid ventricular response, the clinician can input the oral and IV medications that they have used to treat AFib in the last 24 hours, as well as acutely during the RVR episode, and the tool will provide recommendations on reasonable next steps based on parameters such as blood pressure, serum creatinine, and structural heart disease. This tool is being tailored to the recommendations from the 2023 ACC AHA HRS guidelines for AFib, just released 2 months ago. Moving on from AFib. 600,000 patients in the United States alone are eligible for immune checkpoint inhibitor therapy. Considering that the use of checkpoint inhibitors is projected to rise in coming years, there is an increasing need to appropriately screen and manage toxicities associated with checkpoint inhibitors. Therefore, we designed a cardio-oncology app, a digital tool to assist clinicians to figure out the screening and monitoring strategy needed for any given combination of cancer therapies and patient risk factors. We've expanded the scope of this app from just immunotherapy to all major cancer therapies. This app's also offered in dark mode, which I think is a nice touch by a resident, Dr. Mora. Let's say you have a patient of BCR-ABL inhibitor, imatinib, with a BMI of 31, diabetes, age 62. Let's say they have heart failure, an abnormal ankle brachial index, and arrhythmia, and their QTC is 470. They have elevated troponin and an EF of less than 50% and received anthracyclines before. Give it a second to think, and it'll provide you with the following color-coded Class 1 and 2A recommendations. It will tell you that this patient needs an echo and physical exam at baseline, 3, 6, 9, and 12 months, but lipids, A1C, and ECG at baseline only. It will also give you the prevalence of each cardiovascular adverse effect, so you know which entity to watch out for. Where did we get this information? This tool is grounded in the recommendations from the 2022 ESC Cardio Oncology Guidelines developed in conjunction with the International Cardio Oncology Society. We have covered a lot of ground today on this tour of 7 examples in cardiology from the computational cardiology team at Yale. Through these examples, I hope you can get a sense of the processes, which is invariably sparked by an idea that arises from a clinical problem and can be similarly modeled in other medicine subspecialties. What starts out as a paper sketch is mapped out to account for the possible clinical scenarios in a structured manner. For each scenario, we specify the recommended behavior, the rule used to arrive at that recommendation, and the associated guideline that the rule is grounded in. We design logic flowcharts to outline how the application should decide what to do, and wireframes to visualize how the application should interact with the clinician. Then only the coding and debugging begins. We try our best to provide accompanying educational material in the form of tutorials and infographics to make the website a one-stop shop as an educational portal. We then assess the impact of the educational intervention on learners alongside its public release. At every step, the plan is dynamically revised based on feedback and consensus from all stakeholders. Guidelines exist in every specialty and model the current standard of thinking, but they're generally hundreds of pages long each. Do busy clinicians in your subspecialty who are already overwhelmed with increasing patient care volume and in-basket messages read any of these guidelines from head to tail? These guidelines are just waiting to be transformed into point-of-care tools for decision-making and medical education. Perhaps we could all benefit from a tool that tells us when not to order an ANA and what to do about a positive ANA. There's vast untapped potential. If you're interested in reading more about this topic, please check out our recent review. Today, we focus on locally developed tools as I wanted to give you a window into the process of creating them. But there are others out there in the field that are definitely worth checking out, which we cover in this review. Before we end, I want to make it known that no stock photographs of actual patients or physicians were used. All faces were generated by AI, except faces of team members. These were not enhanced by AI. I'm grateful to many other faculty and fellows not listed here who have indirectly championed the development of these digital tools. There are many pathways for further development, and I'm very open to discussion. To summarize what we have seen in the last 40 minutes, since this was designed to be a 40-minute talk, many aspects of this decision-making in medicine can be modeled computationally. Today, we saw 7 illustrative examples in cardiology. Use of these digital tools can improve clinician understanding of cardiac conditions and bring guidelines by experts to the point of care. This approach may be useful to medical educators in other subspecialties, hoping to create digital tools. But whether improved clinician understanding leads to downstream outcomes should be evaluated in future work. I must thank all members of the computational cardiology team that I'm privileged to lead at Yale, all the residents, attendings, APPs, and students who use these tools, and my family and friends who put up with me. I would like to thank Dr. Windisch, Quagliarello, Dunn, and others for the 2023 Faculty Educational Scholarship Grant that contributed to the ongoing development of Troponin.org. I'd like to thank Drs. Velasquez, Miller, Gandhi, Sufer, Nana, Siegel, and Rhodes for being supportive during my time here and my eventual faculty job search. I would like to thank the AHA and American Society for Nuclear Cardiology for their recognition of GDMT.org and stressingwisely.org. With that, I'm very happy to end on time for the 10-minute question and answer period. You can also email me and tweet me anytime. Thank you.
Okay, great presentation. Questions?
Thank you very much, Peter Ellis, a general internist. This is bewildering, incredible amount of information. I'm struck by the volume of material, how you give credit to so many people who have worked with you. It sounds like you could set up your own company. Seriously, it seems like you're doing both point of care, decision-making for the clinician, but also medical education. And it's really ambitious to try to do both of those. It's very impressive.